Is the slide visible?
Yeah, yeah. Go ahead.
Okay. 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 Good evening to all. So we go on to the next part of toxicology, that's on snake envenomation. So this is a very, very high potential short note. So coming to the introduction, just to give a clarity, the total number of snake bites over the year account for almost 5 million cases. So out of that, 50%, that's almost 2.5 million cases are envenomations. And out of that, 75,000 to 1 lakh deaths occur globally. So with respect to India, the highest reported deaths are in UP, Bihar, and Andhra Pradesh. So three families of venomous snakes are there, which are of clinical importance in Southeast Asia, which all of you need to know about. One is the Elapidae. So the basic thing about them is they have small fangs. So the two common species are Indian cobra, that is Naja Naja, and Crate, that is Bangar species. So the features are they have short fangs, they have a less triangular head, and they have large scales. So these are the three differentiating features for elapids. And commonly they are associated with neurological signs and local reactions. Then you have Viperidae. That is, they contain the true fangs. And under them, we have the Russell's viper, the saw-scale viper, the green tree pit viper, and the hump-nosed viper. So the features over here are the opposite of the elapids. They have longer fangs, they have triangular head with an abrupt transition to body, and a small scale pattern on the head. So these are usually associated with local reactions, hemostatic complications, renal complications, rhabdomyolysis, and some viper can cause neurological manifestations also. Then you have a third classification called colubriae. So this is more in the sub-Saharan areas. So the special features are they have shortened fangs at the back of the upper jaw, and mostly they are associated with coagulopathy, though in most scenarios they are harmless. So here are the three distinguishing classes of snakes. Here you have the elapids. You can see the large snake scales over the head. Then you can see the short fangs. All right. Here you can see the viperids where the fangs are larger. There are small scales over here that are present. And here you can see there is an abrupt transition from the head till the body. And there is a triangular head. So this is characteristic of a viperid. All right. And the one over here that you can see is the colubriae, where the fangs is usually at the back of the mouth. So coming to the venom pharmacology, so modern techniques of venomics, that is basically proteomics applied to venom, such as high performance liquid chromatography and mass spectrometry, have revealed the enormous complexity of snake venoms. So more than 100 different proteins have been isolated from snake venom. Why this is important is many of the clinical features that occurs following snake envenomation has been attributed to all these enzymes. So the identified components and physiological sites of action of snake venom determine the spectrum of clinical features commonly seen after the snake bite. So there are almost 100 different proteins. But from an exam perspective, I think it's good to know about at least 7 to 8 of them. So the most important is the zinc metalloproteinases. So these degrade the basement membrane components of the blood cells, leading to endothelial damage and contributing to spontaneous systemic bleeding. Then you have anticoagulant enzymes, especially like Russell's viper venom, which is associated with anticoagulation related hemorrhage. Then you have phospholipases A2 and lecithinase, which cause widespread damage of various tissues. Like in peripheral nerve, it can cause neurotoxicity. In RBCs, it can cause hemolysis. Skeletal muscles, it can cause rhabdomyolysis. And in the vascular endothelium, it can cause capillary leak. Acetylcholineases, mostly seen in elapids, may cause fasciculations. Higher urinodases and endopeptidases are usually associated with tissue destruction at the local site. So this swelling, blistering, tissue necrosis are all attributed to these two enzymes. That is the higher urinodases and the endopeptidases. Then you have the procoagulant enzymes like the serine proteases, which activate factors 5, 10, and 2. leading to the formation of fibrin. Because of the intact coagulation system in the body, most of the fibrin clot gets immediately broken down by the fibrinolytic system. So ultimately, there is a consumptive coagulopathy which occurs. Then neurotoxins, which generally target the neuromuscular junction, which can be either presynaptic and postsynaptic, or it can be both, or they can also affect the skeletal muscles. Now, why you need to know about the presynaptic and postsynaptic is in presynaptic, it acts via phospholipases A2. Now, when it acts through the presynaptic receptors, they are not reversible. So once the action has occurred, the toxin effect is produced. And if it is going to be presynaptic, there is not going to be any reversible activity following anti-snake venom. So it takes days to weeks for recovery of function as the axon regenerates. Then you have postsynaptic, where the target acetylcholine receptors are on a muscle end plate. They respond to acetylcholine, and these are the ones which can be reversed with antivenom or anticholinesterases to an extent. So these are the basic enzymes which you need to know in relation to venom pharmacology. So coming to the clinical manifestations, the first one you need to keep in mind is about the local reactions. So there can be pain, blistering, swelling, tissue necrosis, ecchymosis, regional lymph node swelling with tenderness, and fang marks is usually seen in most cases. So this is the first thing you need to always have a look into. So many a times when we examine a patient, we always just look at the bite side. All right. It is always important to look at the ipsilateral inguinal nodes because the spread of the toxin will definitely cause lymphangitis and they will cause lymphadenitis also. So you always need to check those areas also. Then coming to the neuromuscular junction, it can manifest as ptosis, dyspnea, diplopia, nystagmus, bulbar palsy, where there can be pooling of secretions in pharynx, limb weakness, usually flaccidity with decreased or absent reflexes. So to differentiate between a presynaptic and a postsynaptic, you can go with the neostigmine test. So you first give atropine 0.6 milligrams or glycopyrrolate 0.2 milligrams. Then you give neostigmine in a dose of 0.025 milligrams per kg and observe for an improvement in ptosis with an upward gaze and resolution of respiratory weakness within 30 to 60 minutes. If it is present, then it is likely to be a postsynaptic paralysis, which will be responsible to anti-snake venom and anticholinesterases. Then coagulopathy is the next clinical manifestation that can be there. Can manifest as epistaxis, gingival bleeding, oozing from gingival sites, bleeding from many puncture sites, or clinically evident bleed like hemoptysis or hematemesis. So, like I said, because there is going to be consumption coagulopathy or the toxins itself can lead to anticoagulation, it is going to cause a derangement in your hemat parameters like thrombocytopenia, anemia, deranged INR or APTT, raised D dimer, and elevated WBCT, that is whole blood clotting time, more than 20 minutes. Then shock. It can be either absolute because of plasma leak of massive bleed, relative hypovolemia because of vasodilation of the splanchnic vessels, or myocardial depression, or a combination of all three. So the usual manifestation can be with hypotension, tachycardia, and signs of poor peripheral perfusion like prolonged capillary refill and lower urine output can be there. So this can manifest and can be identified as abnormalities on ECG and echo. So if patients present with shock, hemodynamic monitoring would be necessary. So rhabdomyolysis can be identified by the presence of red and brown urine, and oliguria can be there. So you need to check the urine for myoglobin. Other tests that you can do to identify is assess for presence of elevated serum creatine phosphokinase, serum potassium, and serum creatinine. And other manifestations that can be there are lethargy, seizures, nausea, vomiting, and abdominal pain. So these are the general clinical manifestations that you always need to look into in a case of snake envenomation. And another important thing you need to keep in mind is even though elapids are usually associated with neurotoxicity and viperids are associated with other manifestations, it's not necessary it has to be a standard rule. That can be overlap of features because, like I said, venom pharmacology will be common to most of the snakes. So they can produce a wide variety of symptoms, but the commonest features that are seen in elapids are neurotoxicity, and the commonest in viperids are rhabdomyolysis, coagulopathy, and rhabdomyolysis, coagulopathy, and other hemostatic complications. So here are just few images. Here you can see local reactions. Then here you can see lymphangitis that has occurred. Then you can see ptosis following neurotoxic envenomation. Then here you can see gum bleeding, gingival bleeding. And here you can see pituitary apoplexy, that is in extreme cases. So for diagnosis, important is about the history. So you need to inquire about when and where the bite occurred, the description of the snake if possible, then any symptoms and timing of onset, the initial treatment received, any recent ethanol or recreation drug abuse, relevant medical history and medications, or if there was history of a previous snake bite. If it was there, you need to also inquire about the history of ASV, if it was given or not, or any reactions in relation to that. Then you look for clinical manifestations, local reactions, neuromuscular signs, coagulopathy, shock, and features of rhabdomyolysis. Then the initial lab test. So you do a complete blood count, coagulation profile, renal function test. Then you assess for hemolysis. You do a pee smear, LDH, bilirubin, direct bilirubin, and a direct Coombs test. Then echo to assess for myocardial dysfunction if it is present. Ultrasound thorax to assess for effusions or volume overload, and Doppler of the affected limbs to assess for deep vein thrombosis. So this should be the general lab protocol that you need to keep in mind. So coming to whole blood clotting time, so what you need to do is you take 2 ml of a freshly sampled venous blood in a small, new, dry glass vessel. Leave it undisturbed for 20 minutes at ambient temperature. Tip the vessel once. If the blood is still liquid, that is unclotted and it runs out, the patient has severe hypofibrinogenemia as a result of coagulative and consumptive coagulopathy. In case you feel little doubtful, then you can repeat the test. Now, the important thing is this test is mostly done in the emergency setting or in a resource limited setting. In setup where mostly the tertiary care setups where you have access to coagulation testing like fibrinogen, PT-INR, APTT, whole blood clotting time is not routinely needed. This is as per the National Rural Health Mission guidelines from India. So one other thing you need to keep in mind is if the vessel used for test is not made of ordinary glass or if it has been cleaned with a detergent, its wall may not stimulate the clotting of the blood sample because of the surface activation of factor 12 and Hedgeman factor, and the test may be invalid. So this is one thing you need to keep in mind. So differential diagnosis. So when you're mentioning differential diagnosis for any kind of a disease, always mention it in what, in relation to what. So in relation to snake envenomation, the commonest problem is in relation to neurotoxic snakes. Neurotoxicity. So it may be difficult to identify it immediately. If the history is pretty straightforward, it's not a problem. But if they present with weakness as the primary problem and there is no prior history available, you need to keep other differentials in mind. So, tick paralysis, OP compound poisoning, botulism, GBS, myasthenia gravis, and myopathies like polymyositis, steroids, or hypothyroidism need to be in the back of your mind in scenarios where you don't have a clear history. So, coming to the treatment, first aid, first reassure the patient. 70% of snake bites are from venomous species, and even if it is a venomous bite, only 50% envenomate. Rest are dry bites. All right. So, this is the important thing that we need to keep in mind. Immobilize without compression. Get to the hospital immediately. Inform the physician of any symptoms and tetanus prophylaxis. So you go with TT 0.5 ml IM. If coagulopathy is there, first administer ASV, then give TT. So this is the general norm. No tourniquet, strictly no tourniquet. So coming to the treatment, we have supportive management, that is airway breathing circulation, anti-snake venom, and treatment of various complications related to snake bite. So coming to ASV, it is an immunoglobulin purified from plasma of horses and sheep, hyperimmunized with venom of one, that is monovalent, or more, which is polyvalent snake species. All right. So Antivenom is the only specific antidote for snake venom. The most important decision is to give or not to give. So the indication is if you have signs of snake envenomation, then you need to give it. So 1 ml of ASV neutralizes 0.6 milligram of cobra and Russell's viper. All right. And 0.45 milligram of great and saw-scaled viper. So it is produced both in a liquid and lyophilized form. Both are equally effective. The liquid form needs to be kept in cold chain and has a shelf life of 2 years. Whereas the lyophilized form needs to be just kept cold and has a shelf life of 5 years. So prior to usage, it just needs to be reconstituted with 10 ml of distilled water or normal saline. So in India, only polyvalent vaccine is available against cobra, Russell's viper, great and saw-scale viper. It is not effective against pit viper or sea-scale viper. It should be given intravenously and within 48 hours. Intramuscular has altered bioavailability, plus there is a risk of hematoma, so it is not recommended. And there is no dose adjustment in pregnancy and children. The dose, you have a classical regimen and an alternate regimen. The classic regimen, you first give 10 vials of ASV diluted in 250 to 400 ml of 5% dextrose over 30 to 60 minutes. If there is no improvement in 1 hour, then you give another 10 vials. The alternative regimen, if the patient is in coagulopathy, is to first give 10 vials IV, then 10 vials every 6th hourly till the coagulation parameters normalize. So these are the two regimens that can be utilized. So the rationale is the dose of venom injected is around 5 to 150 milligrams. So each vial neutralizes 6 milligram of cobra or Russell's viper and 4.5 milligrams of crate or saw-scale viper. So the total required dose ranges from 10 to 30 vials. So with 30 vials, no response is seen, it is less likely to respond to ASV after that. So that is the important thing that you need to keep in mind. So strict monitoring of patients on ASV therapy is crucial because they can develop ASV reactions. And there is no role for local infiltration of ASV, and failure to respond to ASV can be due to insufficient antivenom, inactive or poor quality ASV, excessive delay in administration after envenomation, and presynaptic neurotoxic paralysis. So these are the four differential thought processes that you need to keep in mind when ASV effect is not seen in your patient. So coming to ASV reaction, it is an IgE mediated. Important thing is no ASV test dose should be given. So you need to administer ASV and assess for reaction. If it is there, then you stop ASV temporarily, start a fresh intravenous saline drip, then administer injection adrenaline 0.5 milligram IM in adults over the deltoid or lateral thigh. Then you go with IV chlorpheniramine maleate 10 milligrams IV. The role of hydrocortisone in ASV reactions is still not proven. If there is bronchospasm, then you go ahead with beta-2 agonists like salbutamol or levosalbutamol. Once the patient has recovered, restart ASV slowly for 10 to 15 minutes with close observation. If no new reactions is seen, then you continue ASV till the infusion is completed. So this is about ASV reaction management. Adrenaline, chlorpheniramine, beta-2 agonists. So these are the three main areas. Hydrocortisone, if ASV reactions is present, even though there is no proven benefit of it. So the observations that you need to see in response to anti-snake venom is patient gets symptomatically better. There will be spontaneous resolution of bleeding. The coagulation parameters usually normalize. In shock patients, the BP starts to improve. In neurotoxic envenomations, because of postsynaptic involvement, usually they start to improve as early as 30 minutes. And active hemolysis and rhabdomyolysis may cease in a few hours. So these are the features that you usually see. The best way of remembering is you know about the clinical manifestations. You will see that there is a gradual improvement over time. So the time period may vary as early as 30 minutes for neurological manifestations till 9 hours for hematological related parameters. So coming for neurotoxic envenomation, if it is presynaptic, it is only supportive management. Intubate, mechanically ventilate, If it is going to be long-term ventilation, you proceed with tracheostomy. So that weaning is more practical and possible. If it is post-synaptic, then you go with anticholinergic therapy like oral neostigmine 15 milligrams 6th hourly or oral pyridostigmine of 60 milligrams 6th hourly with atropine if needed. Coagulopathy, blood products only if there is life-threatening bleed after ASV administration. Heparin, tranexamic acid are not helpful and don't need to be given. If there is shock and hypotension, fluid resuscitation plus vasopressors plus or minus inotropes if cardiac dysfunction is there. And if rhabdomyolysis is there, IV normal saline in volumes to establish sufficient urine output with sodium bicarbonate for urinary alkalinization. If the patient has developed AKI, then there is no role of urinary alkalization. You then assess the need for renal replacement therapy based on the indications. So the three important indications are refractory hyperkalemia, metabolic acidosis refractory to medical management, and oliguric or anuric volume overload. Then coming to wound management, most likely they are going to be polymicrobial infections where they can be gram-positive, gram-negative plus inflora present. So they can manifest from cellulitis till gangrene. So the management can be just from bone debridement till the worst case scenario of amputation. So if compartment syndrome is present, fasciotomy may be needed, and the ideal antibiotic choice would be to go with amoxicillin clavulanic acid because it would cover basic gram-negative organisms and anaerobes. So these are the procedures that are usually done following a local reaction. So fasciotomy is being done, has been done here because of compartment which had developed.